Hi, I'm Nancy O'Neill. What does aging gracefully mean to you? Well, it means something different to everyone. No matter what age you may be, Aging Gracefully on Suncoast FYI offers advice that could help you live a healthier life. Each week we hear from a variety of specialists on a wide range of subjects. So please join us for Aging Gracefully on Suncoast FYI. Tessa is in the studio today to clear up some myths surrounding liposuction. Hi, doctor. Nice to see you again.
Hi, nice to see you.
Good. So let's begin. Clear up some myths about liposuction. What are some of the different procedures?
Yeah. So some of the procedures that are associated with liposuction, I mean, there's so many right now that the consumer could really get confused. But one of the greatest advancements in liposuction came about 15 years ago, 20 years ago, and that was something called tumescent liposuction. So before, all liposuction was done just under general anesthesia. Mm-hmm. You had to be totally asleep because it was quite painful, and they would just, remove the fat So it was kind of a bloody procedure, and it was painful. Yeah. But it worked, Yeah. Although if that wasn't the case, people would never do it.
Right.
But it works. So this doctor figured out that if we add, so during a procedure, what is tumescent liposuction? So what we do is we take some normal saline, right, some sterile normal saline, and we mix with that some lidocaine, which is numbing medicine, and a little bit of epinephrine, which is adrenaline, and that little bit of epinephrine constricts all the blood vessels. And the lidocaine numbs all the nerves and numbs everything. So it's quite possible to do this liposuction completely awake and completely bloodless at this point. My personal preference is to do this with a light sedation because it just takes the edge off. And I found that when people are completely awake, they're
tense, right?
It's an uncomfortable procedure. I want to make it as comfortable and comforting as possible. And when done properly, it really reduces the amount of downtime, discomfort, because the lidocaine will last for about 18 hours after the procedure's over. So you're quite comfortable into the next day. And if you look at pain studies, they show that if you can keep someone comfortable immediately after the procedure, their pain and how they recover and how quickly they recover is much advanced.
Okay, now when you say recovery time then, is this an outpatient surgery, and how soon can they go home after?
Yeah, liposuction is absolutely an outpatient procedure. So people go home. The procedure generally takes anywhere from 30 minutes to an hour and a half, depending on the size. Recovery is anywhere from 1 to 2 days. But I tell my patients 1 to 2 days, 3 days out, I want you to be doing your normal routines. And it's absolutely necessary for them to be doing that. The quicker you get moving, the better you feel, the quicker you'll recover. So I just wanted to mention just one other thing about the liposuction. Because there is another technique. I personally like to use laser. There's also vibrational. There's also water jet. There's lots of different sort of takes on how to get that fat out and how to get it out cleanly and essentially bloodless and painlessly, because there's a lot of associated procedures with using that fat, because we found that there's a lot of stem cells within that fat. So it's paramount that we treat that fat gently.
Okay. So what's the difference between the laser liposuction and the regular liposuction then?
So before, once you put in the numbing medicine and the epinephrine, so everything is sort of constricted and numb, then we take a laser, and it's very small, 1 millimeter in diameter, and you use a laser at a certain wavelength of light, and it basically melts the fat. So it liquefies the fat, or if you use vibrational, that vibrates and liquefies the fat, or if you use hydrodissection, pulses of water sort of loosen the fat and allow you then to suck it out.
Okay, so those are all going into you, whether it's the laser or the
all
water
going
or
in,
anything. Okay.
But then essentially the end point is removing it. All liposuction procedures are invasive in the point where you're removing the fat. But these are through, tiny, tiny fingernail-sized little incisions, no scars, very, very easily tolerated. It's a great procedure. It's one of the top 3 most common procedures in cosmetic surgery.
And they can be done all over the body. I mean, the liposuction can be done on
anywhere,
arms, legs.
Anywhere, yeah.
Okay.
One of the things that I'd like to talk about before we finish is liposuction will do very little if you have a lot of skin. So if you have a lot of skin and a lot of fat, it's not just going to cellophane, like just shrink up once the fat's gone. The skin will still be there. So a lot of times it has to be combined with skin shortening or like tummy tuck abdominoplasty type procedures to remove that fat and skin at the same time.
Right. Which we're going to talk about in a segment coming up soon. Right.
Yes.
Excellent. Well, thank you again for being here, and we'll see you next week.
Thank you.
All right. Thanks, Doctor. Please stay tuned. Aging Gracefully on Suncoast FYI will return after a short break. Co-owner of Therapeutic Lifestyle Solutions and Clinical Director Toya Crutchfield joins us in the studio to discuss non-surgical approaches to spine care. Hello, Toya. Welcome back.
Hello, Nancy. Thank you for having me.
I think this is a very important topic to talk about because we know a lot of people have spinal issues.
Yes.
And it's nice to know that there's an approach that can be a non-surgical approach. So, who is the ideal candidate to you to come see you for this?
One of the things that I would like to point out is, we all hear these terms a lot when we have back pain: herniated disc, spinal stenosis, spondylosis. We hear all of these terms, and not everybody always understands exactly what they mean. For all of us, we're all compressed between gravity and the ground every moment of our lives. So there's really no one that can ever escape eventually having neck or back pain. So we believe that it really starts with the disc. There's, if you look at the anatomy of our spine, you have vertebrae, then you have a disc in between each segment.
Right.
That creates like a shock absorber.
Right. There's cushions in
There's
there.
a cushion there.
Okay.
And that shock absorber also creates a space for the nerve to come out. There's a spinal nerve at every level. When that disc starts getting in trouble from both compression of gravity and our lives, everything in front of us, everything we do is a forward bent posture. Right. As those things start happening, that disc starts decreasing in size. It's also like 95% water, so over time, as things start drying out a little bit, it starts getting thinner.
Right,
when
it's like that cushion starts compressing.
Absolutely, it does. And it's kind of like, the analogy I like to use is like when you squeeze a balloon and it just pops out bigger somewhere else. So as that pinch starts occurring, that compression starts occurring, that disc can start scooting out from between the vertebrae. It can kind of come out of the sac that it's supposed to sit in. As that does that, then it allows the bones, the vertebrae, to start getting closer and closer together. It closes off that canal, and it can start putting pressure on that nerve pretty quickly even. When that happens, when the size of the canal becomes smaller, that is what is known as spinal stenosis. And people hear those terms and they don't realize that it does start with the disc. And none of us can escape that.
So what is your approach that you take differently than, say, if someone had that situation and they went to see a surgeon?
I really, I've been so looking forward to talking about that with you because our center is so very unique. We're not like every other outpatient physical therapy center out there in that we specialize in treating people with back pain because knowing that 99% of everything that happens there starts with the disc. And 80 to 90% of the whole entire population is going to eventually have an issue with that. We have come up with an approach. My partners out of Ohio set up a great protocol that includes 3 different aspects. One starts with manual therapy. If you don't address the soft tissue around the changes in the joint, then no matter what you do, you don't get a long-term effect. So we do a lot of manual therapy, really working on the soft tissues to lengthen them to allow for the other approaches to work even better. The second thing we do is we have a heated pool, as you know. It's 96 degrees, it's salt water, it's both shallow and deep. The reason it's so important to be on the deep end is because if your feet are on the ground, you're not really decompressing. You're still in the compression stage. So we put people in the pool with using some flotation devices, using a therapist, doing very slow, methodical movements. It's not an aerobic movement. They're not in there swimming or treading water or anything like that. This allows for almost like a traction type effect on your spine when you do that. They're in there for 30, 45 minutes at a time because, you know, our body doesn't stretch quickly. So once you've got that effect, you've heated them up in the water, you've allowed for some traction, some decompression, then we use actual decompression tables. It's called a KDT NeuroFlex. And the decompression table is one of the most important things about the whole protocol, because it's one of those situations that, as we were talking about a while ago, when everything becomes so compressed, you have to get to the source of the problem and not just treat those symptoms like a lot of other clinics do. So getting to the source of the disc requires being in the decompression table. And it sits there and it actually opens up every segment of your spine. It will open it up for 70 seconds and close it down for 15. And the reason that's important to understand, it's so different from traction. Traction just pulls, you know, from end to end, basically. But that opening and closing kind of creates a vacuum. It creates a negative pressure in there that acts like a vacuum, can actually bring that disc back where it's supposed to, sitting in between the vertebrae. Only then can the disc start healing.
And this is why you have had such incredible results with your patients. Now, I know there's been a lot of pros and cons, and there's a lot of statistics out there for back surgery.
Yes.
But I think we were talking earlier, that really depends on which report you look at.
Which research study. You know, there's so many things like that out there that have over the years been conducted, and depending on which one you look at, they can, you know, they're skewed a little bit here and there. Point being, there's a lot of situations sometimes where a person who is a very appropriate candidate for a back surgery at that time with their doctor. They go through their evaluation, they determine this person is appropriate. They don't always necessarily give the results that they're looking for. There's often times where there's many occasions of a failed back surgery, if you will, where the person doesn't get exactly the result they're looking for. They don't necessarily come out pain-free. And because of that, we try to do everything from a non-surgical standpoint that we can. Now, there are situations if a disc gets to a point of what's called sequestered, where it is just, there's no hope for that area. That person still may have to have back surgery. But 80 to 90% of the people who come through our program and do their part, you know, they have to participate in this and make some lifestyle changes, do some different things, will never have to have back surgery.
Well, and that's it. We've said this before. Why not go and find out before you go the surgical route?
Absolutely.
I mean, it just makes sense to do anything that you can do holistically. And on your own. So how can patients come and see you? How can they get started on their treatments, Toya?
In the state of Florida, we're actually allowed to do a physical therapy evaluation without a doctor's order. But for the most part, most of these people who have experienced what we've just talked about here today have been back and forth to their doctor. Some are in pain management, some are already receiving a lot of cortisone injections and different things. So you can get a prescription from your doctor to come for physical therapy. You come in, we set you up for an evaluation. We also make sure that when they come in, we go ahead and run all the benefits and everything else. So we try to remove any barrier to treatment. We want to make sure that patients understand exactly what our approach is and what they, you know, what their responsibility would be, if any.
Good. Well, thank you. We're going to see you again soon, and we'll talk a little bit more about what you do and why you get the great results you do.
Thank you so much. I really enjoy being
Great.
here.
Thank you. Thank you for tuning in to Aging Gracefully on Suncoast FYI. We'll return right after the break. Dr. Sampson returns today to discuss peripheral arterial disease, or PAD. Thank you for coming back today. It's nice to see you.
Thank you.
Could you tell us what PAD is?
So it stands for peripheral arterial disease. So as everybody knows, the body has arteries and veins, and we've discussed veins before. But it's the arteries that really are so much important to your body because they take blood out to supply the tissues. And if you have a problem in the arteries, then your tissues can die. So peripheral arterial disease is where you get a blockage in the artery that supplies mainly the legs, sometimes the arms, but it's mainly the legs. That's why it's called periphery, away from the heart.
Okay.
But it's the same disease process that affects the heart. So someone who has a heart attack, they've got arterial disease of the heart. Someone's got peripheral arterial disease, they've got arterial blockages in the arteries to the legs.
And how is this diagnosed, doctor?
Well, the majority of people have it without even knowing that they have it. But sometimes the doctor will do a pulse examination on your legs and find that your pulse is not good, or you'll complain of a symptom of peripheral arterial disease, which is mainly trouble with walking. So the person they go for a walk, they start to get discomfort in the leg, they stop walking, the pain goes away. And that's because when they're walking and they don't have enough blood supply, acid builds up in the leg, and that causes pain. And when they stop walking, the acid washes out, the pain goes away. There is a medical term for this, it's called claudication, but you're not supposed to know that.
Okay, you're not supposed to know that, or it doesn't, I mean...
Well, we know about it, but you don't have to.
Right. So if, for example, I mean, the average person, they're walking, this happens, is there a numbness, or is there a tingling, is it just a pain? I mean, what is the most common?
As the blockage gets worse, there are going to be more and more symptoms. So usually the walking distance gets shorter and shorter. And then you get pain even at night while you're sleeping, because when you're lying flat, you don't have gravity to help the circulation. So those people say they have to get out of bed to let their feet dangle over the edge of the bed to get rid of the pain. And then as things progress, they can actually get an ulcer of the skin where they get a wound, or even gangrene.
Oh my goodness.
So we as doctors, we do have tests that we can do, and one of the simplest tests is to use a thing called a Doppler. It's like a special little stethoscope that we put on the artery, and we can hear the blood flowing, and based on that we can tell whether you have circulation trouble or not.
Okay. And what is the common treatments for PAD?
Well, the majority of people don't need any treatment per se for the blockages. They can live with the blockage. Treatment would be a quality of life decision. So most people can get around adequately. They don't need any treatment. Certainly they need medication to prevent the blockages. So as I've said, this is the same blockage that causes heart attack, same blockage that causes stroke. So a lot of people are put on drugs called statins that change cholesterol, because that's one of the causes of blockages. Some people take aspirin. Some people take a drug called Plavix. People need those medications, but do they really need some invasive treatment for their leg? That really depends on their quality of life. So we tell the patient, if I had a treatment that was painless, cost nothing, and was guaranteed to work, they would have it. We don't have such a treatment. So our job as the vascular surgeon is to explain to the patient what the different treatment options are, and then let them make a decision.
Okay, and that's it. I mean, everybody should be informed, and unfortunately, like you've stated in the past, people aren't given all the information that they need.
I think one of the reasons that I'm here again, as I was the last time, is to tell people that they shouldn't be forced into having treatment. This is a quality of life decision. So if the doctor says to you, you're going to lose your leg unless you have this treatment, that may actually be true if you've got gangrene, or if you've got a sore that's not healing. But if your only trouble is walking, you're not going to lose your leg unless something terrible happens. So, so be an educated consumer of information. Know what you're in for.
Okay. Now, are all doctors able to diagnose and treat?
Most doctors
PAD.
can diagnose and treat PAD, but there are various treatments. They can be a balloon procedure or a stent, or it can even be a bypass operation. So the only group of doctors that can do all of that are obviously surgeons. So vascular surgeons can give medications, they can treat with balloons and stents, and they can do surgery. But there are other doctors like cardiologists, interventional radiologists that can do balloons and stents. But not everybody should have a balloon or a stent. So we kind of feel you should go to somebody that can offer you all the different treatments.
Okay, now when you say quality of life, so if somebody decides that they don't want to have anything done at all, is it a gradual thing that will just over time?
The majority of people don't get worse.
Okay.
So we tell them to exercise, because the more you exercise, the more you build up what we call collateral arteries that will kind of go around the blockage.
Right.
And patients can often do very well just in an exercise program.
And it will increase your blood circulation, your blood flow.
Correct.
Okay. Well, again, thank you for all the
Our pleasure.
information. I really appreciate it. Thank you for tuning in to Aging Gracefully on Suncoast FYI. To find previous episodes, go to snntv.com under programming. See you next Saturday and Sunday at noon.